Good morning, ladies and gentlemen. I think let's start today's lecture, which is on retina tumors. We'll start with the commonest, retinoblastoma. Retinoblastoma is the most common primary intraocular malignancy of childhood. It accounts for 3% of all childhood tumors. It's a rare tumor and occurs in 1 in 1,700 live births. It's a rare tumor, but you see it even here in Zambia, in other countries I've seen it too. What's the pathology in retinoblastoma? The histology. The tumor is composed of small basophilic. When we say basophilic, bluish sort of when you stain, which they refer to as retinoblasts with a large hyperchromic nuclei and scanty cytoplasm. What you have, the tumor differentiation is characterized by formation of rosettes. I will show you the type of rosettes which are there. There are flexular winterstena rosettes, which consist of got a central lumen which is empty, surrounded by columnar cells. You will see that very soon, just wait. Then the nuclei of the cells lie away from the lumen. They are more like at the base. Cells form a round entangled mass of eosinophilic processes. Then you have florets, where you have tumor cells which exhibit photoreceptor differentiation. I think the best way to see is this. This is the flexular winterstena florets. You can see the cells are all around here. The center is like empty.
Okay. 15 and time. Yeah, right?
So you've got, this is the pattern you get when you get a specimen and you stain it. These are the florets. You've got cells all around with literally like an empty space in there. What is there is the fibers. The cells are the ones stained bluish here, all around like that. So when you are making a diagnosis, you get that, you stain it, straightforward, you should be able to say, this is a retinoblastoma. This is a better picture. You can see stained cells, but all these round like that. The center is empty, round like that. Okay. This is a differentiated tumor, undifferentiated tumor, in the sense that there are no patterns, the patterns you saw here. Here you've got this round, this is a differentiated tumor when you've got this. This is differentiated tumor. They form into a pattern of florets, but this is undifferentiated. It's all a mass of stem cells, but you can't tell if this specimen is brought to you and you don't know where it has come from. But once it has differentiated, like in this one and in this one, you should be able to make a diagnosis. The pathologist should be able to make a diagnosis that this is retinoblastoma, florets. This is undifferentiated. These two are differentiated. Patterns of tumor spread. There is what is called endophytic one, where growth into the vitreous. You know that the whole eyeball, inside you've got the vitreous, Then out of the around the vitreous there is the tumor, the retina. So when you say growth into the vitreous, it means the whole tumor cell is growing, the whole mass is coming into that empty space. Exophytic means it's growing into the subretinal space, growth into the subretinal space, causing retinal detachment. You've got tumor here. I don't know how I can demonstrate it. You've got the tumor, the retina. The retina is above the the tumor cells grows into the subretinal space, or can grow into the vitreous. You've got a layer of retina can grow inside into the vitreous, or below the retina into the subretinal space. Once it goes into the subretinal space, because of the mass now which grows there, the retina gets detached. Is what is called retinal detachment. As a major growth into the subretinal space, it causes retinal detachment. You can have growth into the optic nerve, invading the optic nerve. You know that the optic nerve starts at the optic disc, because the fibers from the various cells within the retina, they exit the eyeball through the optic disc, then out as a optic nerve. Each cell within the retina has got a fiber which comes through the optic disc and out of the eyeball. Once it's out, it's referred to as the optic nerve. So you've got, for example, to the right and left eye, you've got an optic nerve coming from the right, you've got an optic nerve coming from the right, the left eye. At some stage, these optic nerves fuse. You remember we're talking of the medial, from the medial retina in this eye, joining with the lateral retina in the other eye to make the optic tract. Half of this joins with the other one. This, the medial one, joins with the lateral one. These now become optic tracts. Where they join is chiasma. Out of the eyeball, each bundle which comes is the optic nerve. Then chiasma, after the chiasma is optic tract. So you can have tumor cells coming out, even invading the optic nerve. Spread of tumor along the subarachnoid space to the brain, or you have diffuse infiltration of the retina without exophytic or endophytic growth. Where the tumor, because the tumor is coming from the retinal cells, you can have that tumor cells, instead of coming along with the optic nerve, it goes into the retina. It diffuses into the retina. And the retina, we know that it's inside there. So metastatic spread can occur to the regional lymph nodes, to the lungs, to the brain, and to the bone. Metastatic spread goes in the bloodstream. That's how the cells eventually end up in these other lymph nodes, in the brain, the bone. Those cells have spread from the tumor within the eyeball through the bloodstream, through the lymphatics, and they end up with those other sites. This is the endophytic spread of the tumor from the retina. The tumor goes into inside the cavity, vitreous, and you can see it as a white ball. This is endophytic spread of the tumor. This is dilated pupil with detached retina. You can see the retina, it's like a thin layer. It's because there is fluid below that layer. There is fluid, it's detached. If it's not detached, you will not see that fluid clear area. It's like a transparent membrane. Yes. Because behind there, which is below the retina, there is fluid which has led to detachment. So separation of the retina away from the other layers is what we refer to as retinal detachment. Genetics of retinal detachment of retinoblastoma, it results from malignant transformation of the primitive retinal cells before final differentiation. Retinal cells, before finally differentiating into mature retinal cells, you know, retinal cells are the ones responsible for appreciating the light, isn't it? Light has to go through up to the retinal cells to activate the retinal cells. Then the impulses get away from there into the brain. Then you start appreciating that, oh yeah, I can see or I cannot see. If the cells are dead, even if the light is shown there, you will not be able to see. So a retinoblastoma comes because of this malignant transformation of the primitive retinal cells before final differentiation. So those cells before final differentiation into proper retinal cells, which can, where light can be appreciated, they change and become malignant. And that's the retinoblastoma. But they come from the retinal cells, primitive retinal cells. Before maturity, they end up into tumor. The other thing is, this tumor may be inherited or non-inherited. What is called heritable or non-heritable. Heritable germline retinoblastoma accounts for 40% of retinoblastomas. In other words, 40% of retinoblastomas are inherited. They are inherited. 60% are not inherited, but it's sort of sporadic. They've just occurred. So associated with advanced paternal age, suggesting mutation in the father's sperm. One gene is mutated in all body cells, and when a second gene undergoes mutation, the cell undergoes malignant transformation. These tumors are associated with fathers who are old. The germ from the father, from the sperm, is this malignant transformation, and the child gets the tumor. Not the father. The father it has been inherited from the father because of malignant transformation of the sperm from the father. But the tumor occurs in the child. This is associated with old people trying to, to marry. You can't stop them because you don't know if you're an old person, whether your child is going to be okay or not. So, but it has been observed that most of these cases, they are associated with fathers who are old, and there is this malignant transformation from the sperms of the father. Important points to note here is, because of the retinal precursor cells contain the initial mutation, these children develop bilateral or multifocal tumors. So you can have one or maybe many sites within the eyeball. Heritable cases also have a predisposition to other non-ocular tumors. Apart from having the retinoblastoma, which is an ocular tumor, those that are predisposed may also have other tumors. not necessarily ocular. Tumors like osteosarcoma or melanoma or brain and lung malignancies, all these may also be associated with an individual having a retinoblastoma. Mutation is transmitted in 50% of cases, but because of incomplete penetrance, only 40% of offspring. What is happening now? Going away. Huh? That's what is remaining. But I've just been talking. Huh? Oh, I see. Warning. Okay. So mutation is transmitted in 50% of cases, but because of incomplete penetrance, you only see it in 40% of the offspring, which who are affected. Note, if a child has heritable retinoblastoma, the risk to siblings is 2% if parents are healthy. You understand that one? Okay. A child has heritable retinoblastoma. The risk to siblings is 2% if parents are healthy. The siblings, the risk to the children. The parent that can have retinoblastoma, heritable, the risk is 2% there. The risk to sibling is 40% if parents are affected. And about 15% of patients with hereditary retinoblastoma will show unilateral involvement. Can be bilateral, but only 15% are bilateral. Maybe. What page is this? 11. Let me go on this one. This is clinically what we call leukocoria or white pupil. That white tumor inside the, in the vitreous, growing into the vitreous, looks like white. When you dilate, the eye looks like that, and you refer to this as white pupil. And this is what is also known as leukocoria, right eye. Yeah, this one. It's the tumor growing within the vitreous, from the retinal layers into the vitreous. It's in the right eye. Here, there is nothing. You can see red eye, inflamed eye, but you can see also slightly white. If you don't have a proper history, you might think it's a traumatic cataract. Because of the inflammation here, inflamed sclera, especially limbo, bilimbo, and the whitish appearance there. Here, there is nothing. This is a red eye due to uveitis following retinoblastoma. This white thing, when you dilate this pupil, that's the tumor cells behind there. So the patient can also present with what appears to be uveitis. The initial impression might be maybe this person was punched, and this could be also a cataract. Then they also appear like that. But if they say, no, this child was not beaten, it just occurred on itself, you must be aware that this is uveitis, retinoblastoma presentation. No history of trauma. The initial impression might be like that. But if they insist there was no trauma, you should be thinking of uveitis presentation in a retinoblastoma. There can also what is called pseudohypopyon. What is hypopyon? It's this fluid level. Normally you find this in cases of inflammations, where there is inflammation in the eye. They have infection inside that pass in the anterior chamber, forms a fluid level. When I say anterior chamber, in front of the iris, as you are standing, the fluid level settles down. So you have a fluid level. That is what is referred to as hypopion if it is infection. But this one is not due to infection. These are tumor cells. That's why it's being called the pseudo-hypopion. Why is it pseudo? Look, if there was inflammation, if this is inflammation, true pass, there should be some evidence of inflammation on the limbus here. This would be red completely. Then you would, if this is completely red, then you have a fluid level, you are most likely dealing with pus in the anterior chamber. But look, in this particular case, the sclera is all nicely white right up to the limbus, clear cornea, but it gives an impression that there is maybe there is a fluid level within the anterior chamber, but with no evidence of inflammation. This is pseudo-hypopion, very common in retinoblastoma. Tumor cells have spread into this level. In this case, you have now tumor cells, the retinoblastoma is within the eyeball. It has spread outside the eyeball now into the orbit. And this is how the patient would look like. This one is normal. This one is all tumor. It has got out of the eyeball. It's now in the orbit, which means the whole eyeball is full of tumor. It has got out. It's now within the orbit. Clinical signs depend on the tumor size and the growth pattern. Indirect ophthalmoscope and scleral indentation is performed to assess the tumor age. You have to dilate and see how far it has gone, Intraretinal tumor or endophytic tumor projects into the vitreous. Exophytic tumor projects into the subretinal space, like it's going outward. You have a retina, endophytic goes into the vitreous, exophytic goes out from the tumor, from the cells, into the subretinal space. With a tumor in the subretinal space, there will be detachment of the retina. There will be a tumor mass. When you dilate the pupil, you will see a tumor mass. Then you say there is an exophytic tumor projects into the subretinal. Endophytic inside, exophytic outward. Management, obviously, the first thing is before you manage, be sure what you are dealing with. And to be sure with what you are dealing with, there must be investigations. You do the investigations before you go to the treatment of the tumor. You don't start treatment only to find out, no, it's not actually retinoblastoma. The patient will not thank you. Investigations. Red reflex testing with direct ophthalmoscope. Examination under anesthesia, check for congenital abnormalities of the face. Do tonometry. Tonometry is for what? For pressure. Not for glaucoma only.
I open.
And I open, yes. Tonometry is an investigation you do to check the pressure. Okay? That's the first thing. When it's high, that's when you label it as glaucoma. You understand? Yes. Do measurements of the corneal diameter and intraocular pressure. Anterior chamber examination with a handheld slit lamp. Do the ultrasound scan.
Okay, we now have less than a minute.
So
we can just start another meeting and
okay, let's start. We'll do this. We'll come and start from here.
sure thing. Okay, let's all wait for another meeting.